This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you.
This is going to be Chapter 10, Disorders of Brain Function. Key concepts. Upon completion of this chapter, you'll understand any changes in consciousness may be labeled a seizure. So it's important to differentiate seizures from other life-threatening processes. The importance of patient history and the paramedics need to search for medical alert tags to protect themselves. Now, sometimes we don't get great historians, and they may have a very simply a medical alert tag that explains quite a bit of their medical history that might be pertinent. How pre-hospital care is directed toward ending the patient's seizure, supporting body processes, and protecting the patient from harm. Seizure. Involuntary contractions of voluntary muscles. Caused by an insult to the central nervous system in the brain, results in an altered mental status. And grossly categorized, there's two types. There's intracranial and extracranial. And what extracranial means is any etiology or any cause that might give you a seizure. Table 10.1 is HIT plus 1, which we'll look at here in just a second. Rule out always the top three H's in your initial assessment. And this is Table 10.1 or HIT.1. or HIT plus 1, hypoxia, hypoglycemia, and heat exhaustion are always ones to rule out, or we should rule out. So, is my patient hypoxic? Pulse oximetry is an easy way to do this. Finger stick for the hypoglycemia, and what do they feel as far as body temperature goes? Those are always good ideas to rule out those first three H's. And this is how we might do them. Pulse oximetry on, like, say, a LifePak 12, blood pressure. Blood pressure would be hypovolemia or hypotension, and then hypoglycemia. Any of those very easily can give us a seizure and cause an altered level of consciousness. Psychogenic non-epileptic seizures. Patient with depression, post-traumatic stress, may somatize distress, symptoms and finding, lack of signs of incidental self-injury, lack of incontinence, and these are like pseudo-seizures. Ability to provoke spontaneously, so they can essentially turn on the seizure if they need to. Crying during the seizure, that is not something we normally see with true epileptic or tonic-clonic seizures. Now remember, these are psychogenic non-epileptic seizures. Side-to-side head movements, thrusting of the pelvis, dystonic posturing, closed eyes during the seizure, biting of the tongue tip, not the sides. Now, a person that's early having a seizure and chewing up their tongue, they can't get isolated with it. They're going to chew the whole thing up. Coping mechanism, response to intolerable stress, not intentional. Patient does not make a conscious decision to seize. Treatment, reassurance, supportive care, and this kind of has a poor long-term prognosis. Epilepsy, brief excessive discharge of neurons, not a single disease, reoccurring symptom of several underlying disorders, and is characterized by 2 or more unprovoked seizures. Classifications of seizures. This kind of gets out there, so pay close attention. Be sure you're up on the termage whenever you get done with this section. Focal includes focal sensory and focal motor seizures. Focal motor seizures include automatisms, unconscious repetitious action, and narcolepsy, excessive daytime sleepiness. Simple partial, patient remains unconscious. Complex partial, and on a simple partial seizure, the patient remains conscious but might not really be all there. Lights may be on, no one's home, or it might be isolated in a specific area. Complex partial, patient does not remain conscious. We have a couple different types of this, or a couple different variations. A secondary generalization, or secondary generalized seizures, simple partial seizures, and complex partial seizures progress to generalized tonic-clonic seizures. So both of those, both the simple partial and the complex partial, generally progress to full-blown, what we would consider a seizure. Generalized beginning with the loss of consciousness and proceeds to affect the entire cerebral cortex. Atonic seizures is a sudden loss of muscle tone and collapse of the patient to the ground. Absent seizures, and sometimes kids have these, cause a lapse of consciousness manifested by staring at one spot, the kind of out in la la land, without loss of motor tone, and often last for only a few seconds. Automatisms, repetitious, unconscious movements. Tonic-clonic seizures result from an imbalance in neurotransmitters. The phases of a tonic-clonic seizure are an aura, the tonic, the clonic, and the postictal. An aura is a perception of light or smell, so they kind of know sometimes if they get an aura if the seizure is coming. Tonic, body muscle contraction, and the body appears to get stiff. That's the tonic portion. And the clonic is a series of random contractions of muscles. Postictal, the brain slowly begins to regain function. So this is after the seizure, and the brain's kind of trying to reset itself and get back to normal. Their level of consciousness still may be altered in this phase. Pediatric seizures, febrile seizures are most common, occur early in the patient's fever history, typically when the fever is greater than 102. Generally last for only a couple of minutes. Children tend to outgrow febrile seizures. Absent seizures form a partial seizure, often identified in school-age children, and this is where they kind of stare off and they don't really have focus. You may snap your fingers at them to get their attention, but they're still just kind of blankly staring off into the distance. Involve a loss of consciousness witnessed by staring off without the loss of motor tone. Typical age of onset is 3 to 10 years of age. Juvenile myoclonic epilepsy, highlighted by myoclonic spasm of the limbs, and usually occurs after waking. Upwards of 80% of the patients with juvenile myoclonic epilepsy will go on to have generalized seizures. So a little brief history and classification of seizures. Please go over those terms. History, procedures. What we're going to do is we're going to get their airway, breathing, circulation, or their ABCs, exclude any criteria that we might find in HIT+1 pathologies. Seizures trigger, what might actually trigger them. If they're subtherapeutic or they don't have enough of their medication on board, their anti-epileptic drug is often most common. If they have a seizure history, compare with the previous seizures. Is this like it, or when's the last time you had a seizure, and was it similar to this? Seizure frequency and duration. Increasing numbers of duration of seizures suggest a crescendo or a gradual increase pattern. So if they're having a crescendo frequency, they should probably get reevaluated very, very simply and to see if this might be the development of an extra cellular tissue, like a tumor, or it's just a progression of their disease. As far as the medications go, there are lots of medications that we can use for seizures and lots of medications that they're prescribed. Barbiturates, phenobarb being an example of this. Low doses are effective as anti-anxiety or anxiolytics and anticonvulsants. Hydrodantoins, low cost and effective anticonvulsant, cause less sedation than barbiturates. Benzodiazepines suppress seizure activity, and these are like our Verseds and our Valiums, Ativan, things like that, benzos. Particularly in the cortex, thalamus, and limbic areas, by enhancement of the GABA neurotransmitters. Neural adaptation. Neuron is constantly stimulating, leading to tolerance. Succinamides like Zerontin and Silantin slow nerve conduction, but exact mechanism is unknown on these medications. Carboxylic acids like valproic acid work with interfering with GABA transponase, the enzyme that breaks down the inhibitory neurotransmitter GABA, so they have more GABA available. Gamma-aminobenzoic acid, or GABA, is a naturally occurring CNS depressant. So most of the time we'll excite this or have GABA agonists that will stimulate this or enhance this in some form or fashion, which brings about more of the body's own neurological suppression, if you will. Newer anticonvulsants attempt to either replicate GABA, enhance GABA synthesis, or prevent the breakdown to elevate GABA levels. Neurostimulators, electroneurostimulators, use a system of probes placed in the brain surface that they are attached to generate generate a little electrical firing, and they oversensitize the area. So if they start to have a seizure, the tissue itself is less sensitive and won't follow along with it. Device takes continuous real-time electroencephalograms, or EEGs, that detect spike. When a spike is detected, an electrical stimulus is applied to the brain via the electrodes to neuralize the irritable focus. Vagus nerve stimulator periodically sends electrical stimulus to the brain via the vagus nerve to discharge and neutralize irritable sites in the brain that could induce a seizure. So we have all these types of medications and treatments for seizures. Please look over those as well. Past medical history and comorbid factors. Seizures result in massive pan-cerebral discharge of neurons. Causes and risk factors: imbalance in inhibitory and excitatory neurotransmitters, a disease that alters cerebral blood flow, cerebrovascular disease, inadequate drug levels of anti-epileptic drug, traumatic brain injury, pulmonary disease, and brain infections are just a few. Considerations: last meal, and certain meals are given to patients with seizures, like a ketogenic meal. High fat, adequate proteins, and low carbohydrates is what a ketogenic meal is. Diet offers a pediatric patient a relatively drug-free existence with satisfactory seizure control. Events preceding the seizure, substance exposure and symptoms as far as witness provide all vital insights into the possible source of the seizure. When did it onset? Did anything make it better or worse or provocate it? What was the behavior of the patient prior to? What would the movements look like? And a description of the seizure. Were there any movements of the patient as well? So just a good general overall history. Examination: treat hypoxia, hypoglycemia, and hypoperfusion. Secondary physical examination: level of consciousness, scalp examination to look for trauma, ears and nose for evidence of otorrhea or rhinorrhea, or stuff dripping from the ears and nose. Eye examination of pupils to determine if they got any kind of head injury going on. Doll's eyes are always a poor indicator that everything's normal. A doll eyes is a patient's gaze are fixed when the head is turned. Be sure and keep good C-spine precautions. You can turn the whole board, but their eyes will stay fixed. That's considered doll's eyes, and we see that in a head injury. If the patient does not appear to be recovering, extensive neurological exam, assessment of the cranial nerves, and assessment for stroke. We also have meningeal signs that say that they might have a brain infection. Table 10.5 is a partial list of meningeal signs and symptoms, and this is 10.5. Symptoms are nausea, chills, headache, photophobia, or the light hurts my eyes, or neck stiffness or nuchal rigidity. Signs: projectile vomiting, fever, seizures. Kernig sign. A Kernig sign is severe stiffness of the hamstrings caused by the inability to straighten the leg when the hip is flexed to 90 degrees. So whenever let's say that this is the person, this is their back, this is their hip. So if their leg was stretched out here and you brought it up, their hamstring would start to flex as soon as you brought it up. Now that's a Kernig sign. A Bradinsky sign is another one of these, and severe neck stiffness causes a patient's hips and knees to flex whenever the neck is flexed. So if you have them laid out nice and flat and you flex their neck, that their knees will bend up. Brodzinski's, Kernigs. Any of those are meningeal signs or signs of possible meningitis, along with these that we saw on table 10.5. Assessment. Determine whether it's a seizure, whether it's a syncopal episode, or what has actually occurred. Whenever the patient starts regaining consciousness, start to try to get history from them, they are probably going to have a blanked out section when the seizure occurred. Incontinence, residual paralysis may actually be felt as well. We can't determine if this is from the seizure or not. So if we see this, we're going to err inside the favor and consider that they might have a stroke. And then when the onset of these symptoms were. Syncope should be addressed as a medical emergency. Now, syncope is a fainting spell, but it could be as we were a little bit hypotensive because we were dehydrated, or it could be full-blown, the patient went into VTAC. So it could be cardiac. Anything that would cause a fainting spell from low perfusion should be addressed and looked into for clinical signs and symptoms. Treatment. Generalized seizures. Protect the patient, remove hard objects, and loosen the ties around their neck. Provide support and protective environment. Focus on primary assessment. Positioning. Patient should be rolled to the lateral recumbent position. Suctioning to clear the secretions. Collecting in the buccal pocket. Postictal period. Application of oxygen in immediate postictal period may reverse hypoxia associated with seizure or other known etiologies. Presence of bradycardia, hypertension, and irregular respiration should always be suspicious that they might have intracranial pressure. And this is Cushing's triad. So bradycardia, the patient's hypertensive, and their respiration pattern is irregular. Evaluation and status epilepticus. Evaluation should be constant, and reevaluation is always important every 2 to 5 minutes. Status epilepticus is one continuous seizure evidenced by the EEG, lasts greater than 30 minutes, results generally in brain injury. Prolonged twilight, the patient who remains unconscious for a while, these guys will have a very extended postictal stage. Pathophysiology, ineffective ventilations, acidosis, and hyperthermia can all cause these. So if they're hypoxic, if they're acidic, or they got high temperatures. Treatment, stop the seizure activity. Most effective agents to do so or to stop the seizure activity are going to be benzodiazepines, Versed, Valium, Ativan, and so on. Sudden unexpected death in epilepsy. No known etiology. Possible causes include autonomic nervous system stimulation, effects leading to a dysrhythmia, and respiratory changes due to this. Disposition. Considerations. The patient with status epilepticus should have treatment and transport. Encourage further medical attention. Patient with injuries should be addressed. Pregnant patients. Patients with high cranial pathology. Examples, cancer, meningeal signs, history of anticoagulants. Patients with meningeal signs, specifically. Patients with crescendo patterns, so the seizure frequency has increased. All of these, we should get them checked. So even if they don't want to go to the hospital, you should be an advocate for them and really try to get them to go. You can't kidnap them, but in the same breath, please try to get them to go to the hospital. Conclusion. Our consciousness and our awakened self is essentially our self. Determines our being and who we are. Any alteration has grave implications. Most seizures are self-limiting and benign. The paramedics must keep an open mind and always look for other possibilities. Treat always for the worst-case scenario. References for this were taken from the Professional Paramedic, Volume 2, Medical Emergencies of Del Mar Learning. If you have any questions concerning this chapter, feel free to give me a call. My name is Roy Smith, roy.smith@redlandscc.edu or 405-219-7613. Thank you.